All right, I'm going to talk about endovascular treatment of solid trauma, organ trauma. I'm Chris Hannegan. I'm one of the interventional radiologists at MUSC. It's a pleasure to speak here again. I like this conference. I like embolization. What a great combination. Most of the trauma we see at MUSC is blunt force trauma, motor vehicle accident, high-speed injury, more in the summertime, or a pedestrian struck by a motor vehicle. We do see some penetrating trauma, but in the embolic setting in the angio lab, oftentimes we don't have the opportunity to treat these patients because they have a concomitant bowel injury by a gunshot wound or a stab wound to the abdomen that would affect a solid organ, but it also affects the bowel, and those guys have to go to the OR instead of coming to us where they take care of everything. And in the penetrating trauma world, the ones that we treat oftentimes are the ones that we cause ourselves by doing biopsies, and those are relatively straightforward. You always have to remember it's a multifactorial problem in these patients with blunt trauma. Not only do they have bleeding in their liver or their spleen or their kidney, but they also have bleeding in their brain or a cardiothoracic injury. So we always have to be aware that it's a lot of services involved, and although it's an exciting time for us when we get to help these patients, oftentimes they have to go somewhere else instead. Treatment, when a patient is brought to the OR, if they do have pelvic fractures, you need to stabilize that pelvis, and if you're going to do a pelvic embolization as well as a solid organ embolization, we need to stabilize that pelvis to slow the consumption of clotting factors down there while we're working. And then the next big decision to be made is, where does the patient go next? Do they go to the OR? Do they go to the CT scanner? Do they go to us? The goals of all that triage stuff that's done down in the emergency room is to prevent unnecessary laparotomies, but at the same time prevent wasting of time in an embolic procedure when they should be in the OR because they're bleeding massively internally. So a couple different patients will come in. The first one is the most serious one, is the unresponsive patient with profound hypotension. They need to be rapidly evaluated and volume resuscitated, and if they don't respond to that volume resuscitation, they need to go to the OR as fast as possible. While they're being resuscitated, they can get really quick radiological studies like a chest x-ray or plain fill of the abdomen, look for pneumothorax or pneumoperitoneum or whatnot, but we don't tend to see these people. The people we see are the ones that are hemodynamically stable, and in these patients, almost all of them, before they come to us, have a CT scan because they're not in a critical condition, even though they're in quite a serious condition. And then CT is usually indicate where the patient goes next, depending on what you see, whether they go to surgery or they come to us, or we just observe them, and neither service takes it on right away. If they have macroscopic hematuria, they have a little bladder evaluation or a urethra evaluation as well, but that's not a part of this talk. The management alternatives that we can provide in the middle of the night when these patients tend to come in is threefold. We have occlusion balloons that can control bleeding. And we also have stent grafts that can cover pseudoaneurysms of critical vessels that need to maintain their flow. And the cornerstone of all this is the embolization agents that we use in order to stop bleeding, particularly in solid organs. So we use catheters, microcatheters, occlusion balloons, covered stents, embolic agents, and we all know this. A bunch of different catheters are out there. We all have our favorites for wherever we're going to go. We all kind of do what we're taught to do, and we all have a whole storeroom of these, and some people pick one and some people pick the other, and the best thing to do is the one you like to use the most. And we have microcatheters change the world. They're getting better every year. Every year new ones come out and they track better, and they just have better properties, and they allow us to get very, very distal into these solid organ injuries and preserve as much as that solid organ function as while embolizing the problem area. This is a little cartoon of an occlusion balloon showing you what it does. It's a very compliant balloon that halts flow in a vessel without injuring the vessel. The goals of using an occlusion balloon is to control flow in a patient that needs to go to the OR, but they have a high risk of bleeding in the OR, or to slow flow to allow embolic agents to use, or just to buy a little time, especially in the patient that was hemodynamically stable when they came to you, but then they start crashing on the table and they need to go to the OR because they took a turn for the worse, and this can gain us a little time by occluding the vessel that's bleeding. This isn't a solid organ trauma, but it's a good good example of how an occlusion balloon can help you. This was a gentleman that was impaled while driving through a construction zone, has a 2x4 through his axilla here on right here, coming through here. Here it is on the coronal view. You can see the 2x4 on end. This is what the gentleman looked like when he came to us. He wasn't bleeding from this wound, but the first order of business in the OR was to pull this 2x4 out of this guy's shoulder, and they didn't want to have massive uncontrolled bleeding after they pulled that out. And so we did an angiogram, we got into the right axillary artery, and we put an occlusion balloon up, and then we deflated it, and then we sent him to the OR and says, when you're taking the lumbar out, blow up the balloon, and you'll have hemostasis. And he didn't bleed at all. He shattered his brachial plexus, and he didn't have a very good outcome, but vascularly he was intact, believe it or not. Another example of it's another example of an occlusion balloon. It's not a traumatic setting. This is a patient with consumptive coagulopathy with massive splenomegaly, and Dr. David Adams was going to take this spleen out, and he was worried about having control of the splenic artery and massive bleeding. So before he went to the OR, we put in an occlusion balloon on the right here and showed that we could halt flow to the spleen, and then we deflated it, and Dr. Adams had that at his disposal in the OR to control any bleeding that he might have and to gain some time to control it operatively. Stents help greatly when we need to protect the vessel. We need to stop bleeding from the side of a vessel, but we need the blood flow to be maintained further downstream. This is Dr. Palmaz holding a Palmaz stent. That wouldn't do much good, but if you cover that stent with something and you can make it into a tube, it can be great help in patients with pseudoaneurysms of vessels that need to be maintained. So back in the old days, these are old days because they're before my time. They're not that old, actually. I remember this happening, but I was too young to do it myself. They would get a bare stent, and then they would sew vein onto it and make their own covered stent, or they'd sew bypass material onto it and make their own covered stent. But now we just have a stock room full of them. We just buy them in different sizes and shapes, and they have different properties, and it's great to have them. So this allows us, again, to repair a major vessel that's bleeding and maintain perfusion downstream. It's limited in use in small vessels. They tend to occlude. A downside of it is we need a very large inventory. These aren't cheap, and we need a large inventory of different sizes and different diameters and different lengths, because in the middle of the night, you never know which vessel you're going to need one for. It's not something you can wait a day to order. Embolization is the cornerstone of what we do. It's been around for a while. Endovascular embolization in a trauma patient was first described in 1972 and published in the New England Journal of Medicine. They used autologous clot in a right obturator artery with the patient with pelvic bleeding that wasn't doing well, and it was a technical success, but the patient later died of multiple medical problems. Now we have many different options for embolic agents. As that last talk went into beautiful detail. I don't even have to cover any of this stuff. You can see a big explosion in the 70s and 80s with all these different embolic agents that came, and they're getting better and better and better every year, and they're being perfected. The cornerstone in embolotherapy and trauma tends to be coils and gel foam and glue. Are probably the big three, and every once in a while amplats or plugs. The particles usually used more in a trauma setting or a AV fistula setting. And here's a picture of all those embolic agents that was discussed in great detail in the last talk. Our goal is to stop bleeding, or at least slow the bleeding down enough so that the body can catch up and heal the problem their own, and at the same time limit ischemia in that region of interest and do it as quickly as possible while the patient is still doing pretty well. And it's pretty straightforward how we do it. We do an angiogram. We show where the bleeding is. We get selective in the main vessel that's bleeding, and then we get a microcatheter out as far as we can if we have time to do so, as was covered earlier. And then we embolize with the agent of our choice, and then we do a completion angiogram to make sure the bleeding is gone, and then we close the arteriotomy site.